Welcome to AETCM, the emergency medicine channel. Today, let us discuss about liver function test. You know that when we ask for liver function test, there are a lot of investigations will be there in that panel. Actually, sometimes we may not be knowing why these investigations are done, but we are going to explain what is the importance of each and every investigation in that panel. So the most important investigation in the liver function test panel will be bilirubin. So bilirubin again, you know that bilirubin is elevated in jaundice. Any patient who is having yellow discoloration in eyes, that is called as jaundice. That is due to elevation of the bilirubin in the blood. But elevation of bilirubin alone will not produce jaundice. Only severe elevation of the bilirubin will produce yellowish discoloration. Many patients who is having mild elevation in bilirubin may not have jaundice. So again, if you see the jaundice, it is divided into mild, moderate, severe types of jaundice that we will see afterwards. And normally, the total bilirubin, there are two important types of bilirubin. So there will be a total bilirubin, there will be a direct bilirubin, there will be an indirect bilirubin. So total bilirubin range is 0.3 to 1.1 milligram per deciliter. When this bilirubin is elevated in our blood, you can see yellowish discoloration of sclera, and it can be there in the skin also. Now, under the bilirubin, there are two headings. One is direct and indirect. Sometimes only direct will be given. Then you have to calculate the indirect from the total bilirubin. So, total bilirubin minus direct will give the indirect report. So, direct hyperbilirubinemia is mainly seen in liver disease or post liver, that is obstructive type of jaundice. So elevated bilirubin can be due to either a prehepatic cause for elevation in the bilirubin, that we'll see afterwards, then hepatic cause for hyperbilirubinemia, then post hepatic, that is obstructive type of jaundice. So that is about bilirubin. Now some patients who is having jaundice can have yellow discoloration in urine. That I will tell you why it is like that. So this is your liver. Due to some reason, bilirubin is elevated. So normally bilirubin is produced by RBC breakdown. So this bilirubin is bound with albumin. When it enters to the liver, that will become direct bilirubin. Then the albumin will be removed. So the bilirubin with albumin will not go through the kidneys. So a patient who is having prehepatic hyperbilirubinemia, that bilirubin is always bound with albumin, that will not be going through the kidney. So any patient who is having jaundice due to a prehepatic cause for jaundice will not have urine bilirubin. So that is very important. Urine bilirubin will be positive only in hepatic jaundice or post-hepatic jaundice. Okay, so that is very clear. Now, when we talk about jaundice, that is grossly divided into three major categories. One is prehepatic, hepatic, and post-hepatic. But laboratory wise, it is basically divided into indirect hyperbilirubinemia and direct hyperbilirubinemia. So here you can see the RBCs will break down, that will produce bilirubin. That bilirubin is bound with albumin. This unconjugated bilirubin will not be going through the kidneys or will not be going through the urine. So in a patient who is having prehepatic jaundice, that is mostly due to hemolysis. So hemolysis, patient can have jaundice, but urine there will not be any discoloration. Okay, but in liver there are some reason, hepatic jaundice, some liver disease, many liver disease. In liver, unconjugated bilirubin will be converted to conjugated bilirubin, that will go through the bile duct to the intestine. So if there is a problem here in the liver, the jaundice can be produced, and that jaundice will be conjugated hyperbilirubinemia. Here also it will be conjugated hyperbilirubinemia, and both this conjugated hyperbilirubinemia means the albumin is already removed here. Once the albumin is removed, that can easily go through the kidneys. So hepatic jaundice and post-hepatic jaundice, urine color will be yellow in color. And if you see the causes, there are a lot of causes for indirect and direct hyperbilirubinemia. Indirect hyperbilirubinemia is mostly due to hemolysis. Hemolysis can be due to various causes. If you see the RBCs, you can see it can be something from outside, like antibody mediated hemolysis. Then problem inside the RBC, membrane itself can be damaged. They are called as membranopathies. So hereditary spherocytosis, elliptocytosis, like that. Inside RBC you have hemoglobin. Hemoglobinopathies like sickle cell anemia, thalassemia can produce. And some enzymes are here, that G6PD deficiency, pyruvate kinase deficiency, all these things also can produce hemolysis. And some organism like malaria which enters the RBC and break down that. So many causes which can produce hemolysis, that produces indirect hyperbilirubinemia. And one condition like Gilbert syndrome, there are a lot of conditions, Crigler-Najjar, neonatal jaundice, hepatitis, all these things can produce decreased conjugation. But Gilbert syndrome is a very interesting disease, where in Gilbert syndrome there is a reduction in the function of the enzyme here. So this enzyme function is reduced, so the conversion will be reduced, that's all. But they can have mild elevation in the indirect hyperbilirubinemia. There will not be any problem in the liver enzymes. Liver enzymes are not elevated, there is no problem for liver. Many patients whom we do the liver function test, we can see this phenomenon, that is called as Gilbert syndrome. Actually, Gilbert syndrome is a normal variant. So patient does not have any problem, but when we do a lab investigation, there will be mild elevation of the indirect hyperbilirubinemia. No need for any treatment, no need for any food controlling, nothing is required. That patient is a normal variant, that's all. Again, in direct hyperbilirubinemia, it can be due to intrahepatic cause or extrahepatic cause. So whenever we have a problem like this, a bilirubin is elevated and direct bilirubin is elevated, we have to see the full LFT, we have to see the SGOT, SGPT, albumin, globulin, PTINR, all liver function tests we have to check, because we want to know whether it's a liver problem or extrahepatic, that is post-hepatic. Then we have to do an ultrasound and see what is happening after liver, any stone, stricture, whatever it is. So there are a lot of causes for hepatic jaundice and post-hepatic jaundice that we cannot go now. But basically, when somebody is having a jaundice, elevated bilirubin, we have to see basically whether it is a direct hyperbilirubinemia or indirect hyperbilirubinemia. Indirect hyperbilirubinemia, if the patient does not have any other clinical feature, all other lab investigations are normal, then probably you have to think about Gilbert syndrome. This patient is a normal variant. But if you ask for a peripheral smear, you can look for all these hemolytic changes. So hemolytic anemia is the most important cause for prehepatic jaundice. But if you see the urine, there is no urine discoloration. Whereas post-hepatic and post-hepatic jaundice, patient can have jaundice, patient can have discoloration of urine. So two things are important. Now next thing is we have seen that there are different causes for jaundice: hemolytic jaundice, hepatocellular jaundice, obstructive jaundice. With this chart you can make out what type of jaundice you are dealing with. So if you see the color, hemolytic jaundice will be mild yellowish in color. Hepatic jaundice, but it will be severe orange yellow. Obstructive jaundice, it is called as greenish yellow. Itching is mostly present in obstructive jaundice. Bleeding tendency is mostly there in hepatocellular jaundice. That is very important. Early phase itself you can see the bleeding tendency, because liver is the one organ which controls our bleeding proteins, which produces our bleeding coagulation proteins. Now obstructive jaundice, it is only late phase, because fat soluble vitamin absorption like vitamin K absorption can be reduced in obstructive jaundice. That's why in late phase they develop bleeding tendency. Bradycardia is mostly a finding of obstructive jaundice. That's a very important finding. Anemia is seen mostly in hemolytic jaundice. Splenomegaly is mostly seen in hemolytic jaundice, but even in liver disease also it can be produced. Palpable gallbladder is very, very common in hemolytic jaundice. You can get gallbladder, but normally it is associated with hepatocellular or obstructive jaundice. Bilirubin, elevated bilirubin, mainly indirect in hemolytic jaundice. SGOT, SGPT is elevated in the hepatocellular jaundice. So when the liver is damaged, SGOT, SGPT is elevated. Prothrombin time is not prolonged in hemolytic jaundice because liver is normal, whereas it is prolonged in hepatic jaundice, and it is prolonged due to vitamin K deficiency in post-hepatic jaundice. Albumin globulin is very important because it is another functional problem in hepatocellular problem. Globulin is always higher than albumin in chronic liver disease, whereas in other two conditions, albumin is more than globulin. That's a normal parameter, and globulin is more in hepatocellular disease. Urobilinogen increased here. Urine bilirubin is not seen in hemolytic jaundice. That is, we already discussed that the bilirubin is bound with albumin. That's why we don't get bilirubin in urine in hemolytic jaundice. LDH is mostly elevated in all types of hemolysis, so it will be elevated here. Alkaline phosphatase is very classical for obstructive jaundice. Elevated alkaline phosphatase with mild elevation or moderate elevation in the bilirubin always point towards an obstructive lesion. Now causes, there are a lot of causes. We are not going to that causes now. Now next one is liver enzymes. We know that in liver function test we have SGOT and SGPT. So normal range is somewhere around 10 to 45 here, 10 to 50. You just remember it as 40. The normal enzyme maximum will be 40. Up to threefold elevation, 120, can be okay for many patients. That is, with symptom like vomiting and all, it may be abnormal. Up to fivefold, that is 160. Also, it can be, it is not normal, but no need to worry, because many patients who is having fatty liver, you can see SGOT, SGPT will be slightly elevated, 80 to 120 or 120 to 160. You can see in many patients. But if there is no AG reversal, if there is no PTNR elevation, then all these things are due to the fatty liver. So normally, when the SGOT, SGPT elevation occurs, PT is always, SGPT is always more than SGOT. But in alcoholic liver disease, classically SGOT is more elevated more than SGPT. Now we have to see the elevation can be in small amount or in large amount. So normally mild elevation in hundreds, like you see 150, 160, 170, 190, 200, in that range if it is elevated, that may be an initial phase of many diseases, including fatty liver. Many patients who is having fatty liver, initially SGOT, SGPT will be mildly elevated. But whereas in severe disease like acute viral hepatitis, chronic hepatitis, hemochromatosis, if you see the patient in early phase, that will be mildly elevated. It can be like initial phase of hepatitis, you can see SGOT, SGPT will be only hundreds. So you should not stop it there, you have to follow up the patient. Whereas in fatty liver, most of the time we can see in hundreds. Moderate elevation, again fatty liver, once the patient is developing non-alcoholic steatohepatitis or NASH, this 100 may progress. So 100 may progress to 500, 600 like that. And alcoholism is another important cause. And again, all these things are also seen in chronic liver disease, CLD. So what happens is in acute hepatitis, SGOT, SGPT will be in thousands. But once there is a recovery occurs, you can see that it slowly drops to hundreds. So 100 means sometimes it can be fatty liver, like benign condition like fatty liver and all, but sometimes that may be a recovery phase of a major disease. So we have to be very careful. And severe elevation, that is only seen in very few conditions, in thousands. So that is very important. Some patients you can see SGOT, SGPT in 5,000, 6,000, 10,000 like that. In that, most important condition is acute viral hepatitis. So the most important condition where the patient can have SGOT, SGPT elevation in thousands is viral hepatitis. Then ischemic hepatitis, toxic hepatitis, and other toxins also can be, like rat poison. patient can have very high SGOT, SGPT. Patient who takes paracetamol, high dose of paracetamol more than 8 grams, they can have very high SGOT, SGPT levels. But remember, in a patient who is having some hepatitis, like a patient who is having paracetamol poisoning, he is having 10,000 initial count. So slowly it may increase to 12,000, 13,000, like that it may increase. Suddenly one day you are seeing on follow-up, patient may be in ICU, you are seeing it is drastically dropped to 7,000. That means that is a very bad sign, because all these things are due to the cells. You have a damaged cell. That damage in the cell is actually producing more and more SGOT and SGPT. That enzymes are produced because of the injury. But if there is complete necrosis of the liver cells, then it suddenly drops. So if it is a gradual drop, then it is okay. But if it is dropping like this, acute drop, especially in toxicity, we have to be very careful. Then prognosis is not that good. Another investigation is alkaline phosphatase. Normally you can see the alkaline phosphatase will be 40 to 120 units per units, and if it is threefold elevation of the upper limit 125 to around 350, if that much elevation is there, then you have to be very careful. Alkaline phosphatase is classically in liver disease, it is due to obstructive jaundice. So you can see here, this is the classical disease which produces elevation of alkaline phosphatase more than threefold. Then obstructive phase of the hepatocellular jaundice. Okay, so I'll explain what it is. So obstructive jaundice means this is the liver, this is the bile which is coming out. If there is an obstruction like tumor, pancreatic enlargement, this is obstructed, then alkaline phosphatase will be elevated. But suppose there is hepatitis, like viral hepatitis, all these areas are inflamed, all the liver areas are inflamed, and the smaller canaliculae in the liver, they are blocked. Here large canal is blocked, but in hepatitis or acute liver inflammation, small canaliculae in the liver will be blocked. This is called as obstructive phase of hepatocellular jaundice. So both these conditions, it can be elevated. Then space occupying lesion in the liver, and some bony lesions also can produce alkaline phosphatase elevation. But remember, in bony lesion, in multiple myeloma, that is also lytic bony lesion, multiple myeloma alkaline phosphatase will not be elevated. So in liver infiltrative disorders, obstructive jaundice, obstructive phase of hepatocellular jaundice, and bony lytic lesions, also alkaline phosphatase elevation will be there. But in multiple myeloma, even when it is a lytic lesion, bony lytic lesion, alkaline phosphatase will not be elevated. So you have to always correlate this alkaline phosphatase elevation with the SGOT, SGPT or GGT, because if only alkaline phosphatase is elevated with some bone pains, you have to suspect some bony lesion. If SGOT, SGPT is slightly elevated, there is a lot of itching, there is jaundice, then alkaline phosphatase elevation means it's an obstructive jaundice. Now albumin globulin is next important thing. Normally albumin is always more than globulin. So in liver function test, what you are going to get, total protein you get, and you get albumin. You have to calculate the globulin. So total protein minus albumin, you give the globulin, and albumin has to be always more than globulin. Albumin is produced in the liver. If there is a liver disease more than 21 days, that is half-life of albumin, normally albumin levels drops down. So the liver disease itself can produce low levels of albumin. There are other conditions like vascular leak also produce hypoalbuminemia, and if you don't take albumin, then also your albumin can be low. But in a liver disease, albumin is slowly dropping down, and because of the inflammation, globulin can be slightly elevated. So in a chronic liver disease where the duration is more than 21 days, you can see the albumin is reduced and globulin is increased, then the albumin globulin ratio will be reversed. Globulin is more than albumin. There are so many other conditions where the globulin is elevated, like multiple myeloma again. chronic illness, immunological disorders, all these things also you can get same thing. But in chronic liver disease, somebody is having a liver disease like elevated SGOT, SGPT, especially when it is in hundreds. Look at the albumin globulin ratio. If albumin is less than globulin, then you have to think about a chronic liver disease. If albumin is more than globulin, then it is a mild or recently onset liver disease. Now, another important functional test of the previous test which we have seen is PTINR. PTINR is a structural problem. When there is a structural damage, PTINR will be elevated. Sorry, SGOT, SGPT is a structural problem. When there is a structural damage, SGOT, SGPT will be elevated. But whereas albumin and PTINR is a functional problem. Albumin is produced by liver, PTINR, that is coagulation proteins, are produced by liver. So when the liver is damaged, what you are going to see is elevation in the prothrombin time. And international normalized ratio also will be elevated. So what is international normalized ratio? This is patient's blood, this is control. Both should be equal. In coagulation parameters, it should be equal. So you should get a 1:1 ratio. But what happens is when the control is 1, sometimes because of bleeding tendency, this will become 1.5 to 1 or 2, 1. Like that it may increase. So when it reaches 1.1 in a normal person, that is a danger sign. Okay. But whereas in chronic liver disease, most of the time what you are seeing is patient can have INR of 2 or 3. For that patient, it may be 2 or 3 for a longer period. Even then they may not bleed. But in acute paracetamol poisoning or drug toxicity or alcoholic induced acute liver injury or viral hepatitis, if the patient's INR elevates more than 1.5, it is a danger sign. Now, there are a lot of causes for which can elevate prothrombin time. We have only discussed liver injuries, but you can see here a lot of other causes also which can produce PTNR elevation. But you have to think about the coagulation pathway here, intrinsic and extrinsic pathway. So these are the causes for isolated, so elevation in the PT. These are the causes for elevation in the APTT. There are very few causes which elevates only PTNR. So PTNR is mainly produced by the problem in the extrinsic pathway. PTNR elevation will be mainly due to extrinsic pathway problem. So PTINR is elevated, prothrombin time and INR is elevated in liver disease, vitamin K deficiency, during warfarin therapy or super warfarin toxicity, factor 7 deficiency. So these are the common causes for isolated PTINR elevation. Now GGT is another important test. You all may be knowing when the patient is taking alcohol. If the patient is on alcohol or if the patient had taken alcohol within last 2 weeks, you can see GGT will be elevated. So if gamma glutamyl transpeptidase is elevated, we should know that patient is taking alcohol, even when some patients may deny it. So you can do a GGT and tell that whether patient is taking or not. There are other causes also like barbiturates, phenytoin, all these things also can elevate the GGT. So all these things you have to correlate GGT elevation with the SGOT, SGPT elevation. Then it is due to alcoholic liver disease. If the SGOT is more than SGPT, then it definitely tells that alcoholic liver disease. So we have discussed some of the major problems of liver function test abnormalities. Liver function test is a very important investigation which all doctors should know, because various reasons which can produce abnormal liver function test. It can be due to the elevation in the liver function test, or abnormal liver function can be due to elevated bilirubin alone can be prehepatic jaundice. In the liver, it can be due to various hepatitis, drugs, toxicity and all. Post-hepatic, it is mostly due to condition like obstructive jaundice. Whatever it is, some patients may require additional investigations like PTNR, GGT and all. Then ultrasound abdomen is a very, very important investigation, because you are going to screen the liver. whether there is a problem in the liver or post hepatic jaundice, what is the reason why there is obstruction. Some patients may require CT scan also. For pre-hepatic jaundice, then you have to do a peripheral blood smear and you have to investigate for hemolytic anemias also. Gilbert syndrome is actually an innocent disease. It's a benign disease where bilirubin levels can be elevated. It's a unconjugated hyperbilirubinemia, but mild hyperbilirubinemia. No need of any investigation, no need of any treatment, no need of any food control for that type of patients. Thank you.